Okay. Great. Then we will share. Hi, this is Omar the pharmacist, welcoming you from Wiltopia Pharmacy for our new event and awesome presentation about a functional medicine approach to the thyroid. Wiltopia is an interesting visionary approach to what pharmacy means to all of us. We are independent, and our healthcare compass is always directed towards the future of personalized medicine and better pharmacy care. We believe in that triangle of care: a patient, a doctor, and a pharmacist. We offer an array of services, commercially available drugs paid through your insurance plan, and we pioneer in compounded custom creations or simply compounds. And in addition to that, we offer the highest quality professional grade supplements, and we simplify your medications, your supplements, and your treatment plans and health goals through pharmacist consultations. And all of our services can be delivered for free to your doorstep in Wisconsin, Illinois, Minnesota, Arizona, Florida, and soon in Washington State. These are the states that we are licensed in as a pharmacy. Wiltopia Pharmacy is honored today to host a webinar with the title of A Functional Medicine Approach to Thyroid Health, presented by Dr. Tiffany Mullen, CEO and co-founder of Vytal Health, a virtual functional medicine approach healthcare company offering top-notch, highest quality patient care at the convenience of your smartphone or iPad. The future of health and wellness offered to patients seeking a different and a step-forward approach to their specific healthcare needs. Prior to launching Vytal Health, Dr. Mullen led Aurora Healthcare's Milwaukee, Wisconsin Department of Integrative Medicine as its medical director, growing it to the largest department in the country. Dr. Mullen is double certified. Sorry, Dr. Mullen is double board certified in family and integrative medicine. She attended the Chicago College of Osteopathic Medicine in Chicago, then completed her family medicine residency at St. Joseph's Hospital and Medical Center in Phoenix, Arizona, where she completed her fellowship in integrative medicine at the University of Arizona in Tucson. Additionally, Dr. Mullen is extensively trained in functional medicine through the Institute for Functional Medicine. Without further delays, I would like to have Dr. Mullen proceed with her beautiful presentation tonight.
Thank you, Omar.
Thank you, Dr.
All
Mullen.
right, now the question becomes, can we do the handoff?
Yes, we can. Let me do it now.
All right. Okay. And hopefully there is nobody knocking at the door that we're ignoring here.
Okay. Let me go here. Let me go there. Gonna do that.
Okay.
And then I'm going to go to Dr. Tiffany Mullen and then make host. Yes.
Yes. Yes.
Okay.
Always the tech stuff that gets you every single time. So I think the plan here is to do the presentation and then save questions, but go ahead and put them in the chat if you don't mind. Put them in the chat. I don't know that I'll be able to see them during the presentation, and I won't be able to see you jumping up and down, but we will take as many questions as we possibly can at the end of the presentation. The presentation is only about 35-40 minutes. I talk fast. And then if there's other questions that don't get answered during this presentation, I'm happy to circle back with those of you who have other things that you want to ask, and we can make sure that everybody gets all their questions answered. Okay, are we ready? All right, everyone's muted. They're like nodding. All right, so can you see my slide here? Omar, can you see it? I can't see everybody when I'm in presentation mode. I'm presuming. Omar, if you're muted, if you could just let me know that we're in good shape here. I'm actually going to end. Omar, are you able to see the presentation when I'm on just now? Can you unmute for a second? Oh, I have to unmute you. All right. I think we're good now. Okay. We just went through this wonderful introduction of Welltopia Pharmacy. So I'm not gonna redo that part. We're gonna move right on to the topic of thyroid, which is actually my favorite topic of all, I think, as it relates to functional medicine. And the reason for that is because it is an area that is so undertreated in traditional medicine. It's one of the most common things that I see that's missed by the traditional medical community. And when I say missed, I just mean that there's a different approach between functional and integrative medicine, functional and traditional medicine, that I hope will be very apparent to all of you listening to this talk by the end of this. So what we're going to learn, we're going to define functional medicine, because I don't know that everybody knows exactly what functional medicine is. So I want to make sure that we're all on the same page there. We're also going to understand the function of the thyroid gland itself. We're going to look at symptoms of both under and overactive thyroid, although we're going to spend the majority of our time talking about underactive thyroid. It's, excuse me, much more common than overactive, but we'll talk about both. We're going to talk about how we, and when I say we, I mean functional medicine physicians, assess the thyroid hormones, and how that differs from the traditional medicine treatment. We're going to look at options for thyroid treatment. We're going to cover medications, autoimmune support, nutritional supplements. We'll talk about food and things like that. So there'll be all kinds of different approaches depending on what you're interested in. And then we're going to go into some other interesting areas about thyroid, the things that may not be familiar to all of you. We're going to talk a little bit about how the hormones work together. Hormones are messaging chemicals, so they all dance together. One of my favorite things is to try to understand how they all work in conjunction, or how they can have difficulties coming together. And then there's actually also some genomic information, in other words, genetics, that we'll be looking at. Totally new area, very interesting area to me, and we'll just kind of touch on that at the end. So without further ado, I want to basically look at how functional medicine is different from traditional medicine.
Sorry, Dr. Tiffany,
yeah.
can I reclaim host and move the slides so I can let people in?
Sure, please. I'm seeing a few people come in, but I don't know that I'm seeing all of them. So yes, go right ahead.
Okay, so I think, or you know what, if you see them coming in, because I see...
I saw one that I let in. Is there anybody else?
Okay. No, that's fine then. I will give the host back to you. I think.
Okay, perfect. Yeah, they do show up on my screen, so I will let them in.
That is great.
And if not, please feel free to interrupt me if I miss somebody.
Thank you so much.
Don't want to keep people waiting in the waiting room. That's just not okay.
Okay.
Okay. Can you see my slide now? My functional medicine slide? Okay, perfect. So just to talk about what functional medicine is, in general, functional medicine focuses on root cause. It is a solution to problems that is actually trying to get at what the underlying cause of the problem is whenever possible. To do that, we actually have longer visits where we take a deeper dive into symptoms. We really understand where people have been medically, from a history standpoint, their family history. And then we do a deeper analysis of biomarkers and lab data to try to derive where the problem might be coming from. And I always talk about this with patients as peeling the onion. We start to look at all of these deep layers of what might be under it, getting down into genetics, getting into hormones, getting into gut, looking at unpacking problems in an in-depth way. I find that the traditional medicine tends to have a very superficial and transactional approach. And so this is the sort of the antithesis of that. We talk about nutrition and lifestyle a lot as a foundational approach to how we treat everything, not just thyroid, but how we treat everything. We can't have good health without focusing on those things. We're very much involved in personalizing the plan, not just because we're looking at different people, but people have different value systems, different ideas about how they want their care to go. And we're looking to try to answer problems, not just provide prescriptions, not just get you rushed out the door with a handful of prescriptions, but rather focus on how do we get you better and how do we discover what's going on. So I want to talk a little bit today about the thyroid. Obviously, we want to do this in the context of a patient. It's always kind of interesting to ground ourselves in what does it feel like to be a patient. So we're going to talk about Elizabeth. Elizabeth is 52. She's been healthy, but all of a sudden she started to have problems with fatigue. She had thinning hair. Her skin started to get very dry and itchy. Her strength and her muscle tone weren't the way that they were before. She's had some weight gain. She does have a family history of hypothyroidism, low functioning thyroid, her mom and her sister. And she's developed some irregular menstrual cycles over the last 9 months and has had no period for 3 months. And based on her age, you might say, well, there might be some change of life, some menopausal symptoms mixed in here. And you're absolutely right if you're thinking that. But she went to see her family doctor, and her family doctor listened to her symptoms and said, well, let's check your thyroid, did a TSH test, and we're going to talk about all the different tests. And that test came up with a value of 5.20. The normal range at that lab was 0.3 to 5.5. And the doctor said, your TSH is in the normal range. I don't think this is related to your thyroid. And essentially said, it's not your thyroid, and I'm not exactly sure what we can do to you, but it must be that you're aging, and it's a normal thing, and go on your merry way. Now, if you think I'm making that story up out of nowhere, if I had $1 for every single time I heard that story from a woman or from a patient, I know I would be retired right now. That's a very common experience for women patients to be dismissed by their physicians when they have a very superficial 10 to 15 minute office visit and they are told that everything's fine and sent on their way. So my question to you, audience, would be, could it be her thyroid? And obviously I'm leading the witness here because we're in a thyroid talk. So of course it could be her thyroid. So she seeks out a functional medicine physician approach. And here's where we begin our journey together. So let's all get grounded on what the thyroid is. And for some of you who have thyroid problems or know a lot about the thyroid, this may be very simple information for you, but I just want to make sure we're all on the same page. So the thyroid is this butterfly-shaped or bow tie-shaped gland that sits right in the front of the neck. It is in between the larynx, which is the voice box, and the trachea, which is the windpipe. And the majority of it actually sits below the collarbone. So it's actually kind of hard to feel it unless it's enlarged or unless it has nodules. It requires the person to swallow in order for the entire gland to move up into the top of the neck and then be able to feel the gland. So it's not an easy gland to examine on yourself for that very reason. When it becomes enlarged or if it's inflamed, sometimes people have symptoms there. But you might say like, okay, wow, based on where it's located, if it became enlarged or if something happened to it, it might actually have some compressive symptoms. It might press on the windpipe or actually disturb the voice. And that may be true. You actually might see somebody who has voice changes or who suddenly becomes, every time they lay on their back, it's hard for them to breathe. That may be a thyroid symptom. So I just wanted to get sort of the anatomy out of the way so that we all understand that. Now, let's talk about how does the thyroid actually work? We're going to talk about this superficially, and then we're going to go into a deeper dive about this. So let's get grounded in the master glands, which are actually located here in the brain. This is obviously a brain cut in half. They are located right behind the eye. This is where the eye would sit. And they are the glands called the hypothalamus and the pituitary. And they are the master glands for all of the glandular organs in the body, including the thyroid, but also the ovaries, the testes, everything that's happening from a glandular perspective in the body is under the direction of the hypothalamus and the pituitary. So they release their hormones, which we're going to talk about in a minute, and that goes down to the thyroid and triggers the thyroid to then make its hormones, T3 and T4, and that feeds back up to the pituitary and the hypothalamus and says, okay, plenty of hormone, need more hormone. So there's this constant conversation that's happening between these glands and the end gland organ, in this case, the thyroid. And that is a conversation we call an axis. So when we're talking about the hypothalamus pituitary thyroid, what we're talking about is something called the Hpa axis. And that's that conversation that's happening. If we dive in deeper here, these are the actual mechanisms of action. So the hypothalamus is secreting a hormone called thyrotropin releasing hormone, TRH. We don't actually measure TRH very much unless we're working up potentially a tumor in the hypothalamus or the pituitary, but it's oftentimes not something that we examine when we're talking about somebody with a thyroid problem. That in turn allows the pituitary to release TSH. There's TSH, thyroid stimulating hormone. That's what TSH is. Thyroid stimulating hormone, as you might imagine, because of its name, actually stimulates the thyroid to make hormone. And here is that negative feedback mechanism that feeds back up on the pituitary, and that's the conversation that's happening in the axis. So because of that feedback mechanism, the higher the TSH, the more hypoactive your thyroid is, and the inverse is true. The lower the TSH, the more hyperthyroid your thyroid is. So people need to understand that inverse relationship there. Now, the thyroid then goes on to release 95% of its hormone is in the form of T4, which then goes over to the liver or the kidney, sometimes both. And with the action of these enzymes, 5-deiodinases and 5'-deiodinases makes both reverse T3, which is an inactive form of T3, and T3, which is the active form of thyroid, which then goes on to tell the body cells what to do, how fast to move, what's the metabolism, how are things moving along. The thyroid also makes a tiny amount of T3 up by itself, about 5%, that also does that same mechanism on the body cells. So this is how it all works. There's a lot of organs involved here, and there's a lot of feedback mechanisms. And when it's working well, it's an exquisite design that keeps everything humming and clicking in the body. So what does the thyroid hormone actually do? It actually does everything. It sets the tempo for every part of the body, our heart rate, our digestive rate, how well we develop and think, our nervous system function, to a certain extent, bone health, how our muscles are contracting. And then obviously it interfaces with other hormones in the body, which we'll get to later in the presentation. If you were to, and it does that by the mechanisms of its hormones, T3 and T4. If you were to flip this gland around, on the backside of the thyroid gland are these 4 parathyroid hormones, which have a completely separate life of their own. They actually are involved in calcium regulation in the body, putting calcium into our bones, taking calcium out of our bones so that we have both strong bones and calcium available to our body. It's also involved to a certain extent in our kidney clearance rate, and it does that through a hormone called calcitonin. So there's really a lot going on in this thyroid, not just the thyroid itself, but in the parathyroid on the backside of the thyroid, a lot of hormonal action here in the thyroid. But essentially, there's no organ in the body that doesn't have a thyroid receptor on it. Just a really important gland for all of our functions. So let's move into what do we mean when we say autoimmune thyroid disease? What we're talking about when we're talking about autoimmunity is that the body has lost its ability to recognize self. So we talk about 2 categories of autoimmune thyroid disease. One is called Hashimoto's disease, and the other is called Graves' disease. Hashimoto's disease is the autoimmune form of hypothyroidism. It is when the body starts developing antibodies, these proteins, these bluish green looking proteins is not what they actually look like, but that then go over to the thyroid gland and attack it, rendering it less and less functional over time. So when we measure autoimmunity, we're talking about measuring thyroid peroxidase antibodies, or what we abbreviate as TPO antibodies. In the case of Graves' disease, which is autoimmune hyperthyroidism, we're actually talking about antibodies, again, proteins that we mistakenly make in our bodies that actually trigger the thyroid to make more and excessive amounts of thyroid hormone, T3 and T4. And therefore, the patient starts looking like somebody who's revved up all the time. We'll talk about the symptoms in just a minute, but it's making more thyroid than the body knows what to do with. We measure that by looking at thyroglobulin antibodies, and to a certain extent, thyroid stimulating immunoglobulins, something we call TSI. When I'm looking at Hashimoto's disease or looking at a patient with a new diagnosis of possible thyroid problems, I typically measure both thyroid peroxidase antibodies and thyroglobulin antibodies, because people can often have both, really interestingly, and be a hypothyroid patient. So I like a full panel of thyroid antibodies, and we'll talk about what we measure in functional medicine when we work up or check for thyroid problems. So what are the symptoms of hypothyroidism, low thyroid? And we can talk about that as Hashimoto's disease, which we just talked about as the autoimmune form, or if it's not autoimmune, we call it subclinical. That's called non-autoimmune. I don't know why we call it subclinical. It's not a very intuitive word. It doesn't really mean a whole lot. But when we're talking about something that's not autoimmune, we're talking about subclinical. So the symptoms are fatigue, weight gain, changing hair, skin, and nails is a really common one. Feeling cold all the time. So this is a person that has 3 or 4 blankets on when everyone else is burning up in the room. Slow digestion, constipation is common. Periods can become irregular in women who are menstruating. A feeling of low mood, depression, or just feeling sort of foggy in the brain all the time. And then obviously there can be enlarged thyroid or thyroid nodules in the case of hypothyroidism from autoimmune or not autoimmune causes that can affect the voice and can be compressive, as we talked about earlier with the anatomy being what it is. But these are sort of the classic low thyroid symptoms. When we talk about high thyroid or hyperthyroidism, we're talking really very specifically about Graves' disease. There isn't sort of a non-autoimmune form of hyperthyroidism, but it's exactly the opposite. So these people feel wired, anxious, kind of like they've had espresso all day. They're very anxious and hopped up. They lose weight without trying, so weight just drops off of them. They have hair loss. They feel sweaty all the time. They have the exact opposite of constipation, loose stools. Again, periods can be irregular in this case. Insomnia because they're so revved up. Palpitations or heart racing, and eyelid symptoms. So when people develop Graves' disease, one of the things that happens is they actually deposit those proteins, those antibodies behind their eyeballs, which then force their eyeballs forward, making it very difficult for them to close their eyelids. And so we actually get this eyelid symptom. It's called lid lag and thyroid stare, where people literally can't close their eyelids. It's a very form of advanced Graves' disease. It's quite striking. I've actually seen it in my career. Very uncomfortable, as you might imagine. Your eyes get very dry, and it's hard to sleep when your eyes can't close. Enlarged thyroid or thyroid nodules is also seen in Graves' disease, and I've seen such bad cases of Graves' disease where you literally see the thyroid pulsating across the room. It's thrumming. It's intense. These people don't feel well. In either case, in hypo or hyperthyroidism, people don't feel well. So I kind of want to get into a little bit about the factors. We're kind of getting a little bit out ahead here, but I do want to talk about factors that affect thyroid function, because there are a lot of factors at play here. We just talked about how the thyroid makes T4, then T4 goes to T3, and then T3 docks at the cell. This is a cell, sits in a little docking station and exerts its influence into the cell through this docking station. That docking station can also be occupied by something called reverse T3, which you'll recall from our earlier slide is the inactive form of thyroid T3. And it can sit in that receptor docking station and actually occupy it. And it doesn't do anything. So it sits there and just sort of keeps T3 from being able to be active. So knowing reverse T3 in certain circumstances can be very helpful. How do we enhance this T4 to T3 conversion? Iron, selenium, magnesium, iodine, an amino acid called tyrosine, and all of these vitamins, E, B2, B3, B6, C, and D, are all involved in the process of making thyroid. Converting is also heavily dependent on selenium and zinc. And then zinc and exercise actually increase the cellular sensitivity to T3 landing in its docking station. Things that get in our way and actually cause us to make more reverse T3 are stress, infection, and trauma. So people who are hospitalized in the ICU oftentimes have very high levels of reverse T3. Radiation, particularly radiation to the thyroid. Fluoride can interfere. Certain medications, toxins have been known to interfere, pesticides, certain heavy metals, lead. Autoimmune disease, particularly celiac, can affect this. And then things that drive T4 to T3 conversion, again, stress, infection, and trauma. Low-calorie diets or extreme weight loss can do this as a sort of stress on the body. Toxins, again, similar ones. Inflammation in the body, kidney and liver disease, and then again, certain medications. So when we're looking at thyroid hormones, oftentimes we want to understand not just the amount of these hormones, but how well are they working and how well are these conversions being supported by the body. That's why looking deeper in many cases is important. So when we're evaluating thyroid symptoms, I think this is where we have a very strong divergence from the traditional medical community. You heard earlier in the presentation that when someone presents with a potential thyroid condition to a traditional physician's office, they typically only run a thyroid stimulating hormone or TSH. In the functional, and that's it. Every so often they'll do a T4 maybe, but typically that's it. There's a TSH, and if it's normal, you're on the road to not having a diagnosis. In the functional medicine approach, we obviously also check TSH, but we check the free hormones, T3 and T4, sometimes total T3 and T4, reverse T3, which we talked about. We want to know what the antibody status is. So we want to look at thyroid peroxidase antibodies. We want to look at thyroglobulin, even if somebody's hypothyroid. And sometimes if it looks like it's a patient that's hyperthyroid, we check the TSI as well. We wouldn't do that in hypothyroidism. But that's not all. We actually keep going. As you can see, the traditional approach is dried up. We're still going. So we look at, and this is not true of every patient, but with the right history and the right symptoms, we might be looking at cortisol, our stress hormone, DHEA, a building block, and assessing that adrenal function. We're going to talk about that more later. We might be looking at sex hormones, depending on the person's symptoms. With Elizabeth and her irregular periods, I would for sure be looking at where is she with these hormones. Sometimes iodine, if urinary iodine level, which is the best way to assess iodine, if an iodine deficiency is suspected, we look at those supportive nutrients. We can sometimes take a peek at genomics or genetics to see if there's some things there that we can influence. And then obviously we're unpacking lifestyle. We're looking at what are your nutritional habits? How much do you exercise? What are your sleep patterns? How stressed have you been? So we're doing a very whole person evaluation and really trying to understand everything that's applicable to a given patient. So this is not my laundry list that I do on every single patient, but this is an idea of what we might do to look at an individual patient's evaluation. So in the case of Elizabeth, and I'm sorry this is a little bit blurry, so this was not a comprehensive evaluation, but just to give you a sense of how I look at a thyroid panel. I want you to look at a thyroid panel like I look at it. The first thing I look at is not what's abnormal, but the first thing I look at is what is the free T3? And this particular test is a blood spot. That means, and also a urine, but a blood spot means that she did this at a test kit at home. She poked her finger, took some drops of blood out of her fingertip and put it on a card, dried it, and sent it to the lab. So believe it or not, we can get all of this information from home. I'm looking at that T3 and I'm looking at that T3 and thinking, man, it's not being marked with a flag, but boy, is it on the low end of normal. That's got my attention right away. Then I'm going to look at a free T4. And even though free T4 may be sort of on the lowish end of normal, it is not the active form of thyroid. So I'm really invested in knowing what this T3 is about. This particular lab did a total T4. Her thyroglobulin and TPO antibodies were both normal. They're never going to be zero. So I'm looking for them to be as low as possible, but I'm not going to treat them if they're not outside the range. But I can tell Elizabeth that she does not have autoimmunity, at least not now. And then I'd be looking finally at the TSH. The TSH is actually flagged as high, just as it was in her doctor's office. But now you can see there was so much more information that we were able to glean, just unpacking it a little bit further. She also has a fairly borderline iodine level that we would probably want to address as well. So I'm looking at Elizabeth and I'm looking at her symptoms and I'm saying, this is definitely a subclinical hypothyroidism and I want to help intervene and treat Elizabeth to make her feel better. And I'd be looking at her hormones and all kinds of other things. But just want you to understand how to look at these thyroid tests and why it's so important to go beyond the TSH. So how do we treat this? Well, there's a traditional approach, which is not wrong, and that is we could use Synthroid, which is T4, only T4, and the generic version of Synthroid, which is levothyroxine, which has been around for a long time, a synthetic form of thyroid hormone. And that you take T4 in as a pill and it converts in your body to T3. And if you do that well, you could feel just fine on that medication. But a lot of times what we see is people don't do very well with that. Either they don't desire a synthetic medication or they don't convert T4 to T3 in the body very well. So we may use those medications, but we also may use a straight T3, something called Cytomel or liothyronine, or we may use T3 and T4 in combination, certain patients, or we might actually use a medication that has both T3 and T4 in it in fixed ratios. Some of these you may have heard of, Armour, NP Thyroid, Westhroid, and Natrethroid are the most common brand names of T3 and T4 combination medications. They're actually made out of pig thyroid. It's an FDA-approved medication, so it's not wacky. It's actually something you can get at your traditional pharmacy or at Omar's pharmacy. It is a traditional manufactured medication. And a lot of people do great when you give them a little bit of T3. It helps their metabolism and it helps them feel better quicker. So all of these options are available. What Omar does in his pharmacy that can be really helpful is he can actually customize your thyroid medication to include T3 and T4 in an exact ratio of our choosing. So we can have this many molecules, this many micrograms of T3, this many micrograms of T4, and we can really fine tune that thyroid medication for you as an individual. And we can do that with immediate release and sustained release so that it's in various combinations. So as you can see, there's a whole menu of options for treating with medications for thyroid, whereas typically the traditional approach only offers the one. But we keep going because we're a functional medicine practice, and we also are thinking about how are we addressing autoimmune if it's there. If a patient has Hashimoto's disease, we oftentimes recommend a gluten-free diet. There are definitely studies supporting gluten as a trigger for increased autoimmunity in certain individuals. And so we recommend a gluten-free diet. We recommend an anti-inflammatory diet. Where there is autoimmunity, there is inflammation, and we want to save thyroid function if we can, and allow the thyroid to work as well as it can, as many years as it can. So we want to lower those antibodies, and we can do that with all of these methodologies. The other cool thing that's really that's available on the market is something called low-dose naltrexone, and Omar has a ton of expertise in this area, something called LDN. It is a medication that is on the market at high doses as something called Narcan. It's actually used in opioid overdose. So if somebody actually overdoses on pain medications or heroin, we use Narcan in traditional medication in high doses to help revive that patient from their overdose. What's been discovered over the last several years is that if we use it at very, very low doses, so we're talking about 0.1, 0.2, 0.5, 1, 2, 3, up to 5 milligrams, very, very micro doses of LDN, it has a very different mechanism of action, and it can actually reverse and suppress some of the autoimmune response. And I've had some great cases where I've actually been able to completely normalize people's antibodies using low-dose naltrexone in combination with these things. So it's very interesting how it works. It's been a really great addition to my toolkit to be able to use low-dose naltrexone. We obviously also use nutritional support if there's deficiency. So we're measuring these things. We're backfilling iodine if it's there. And I say caution in autoimmune because I do think there was a time, and I think it's still out there, where people are using very, very high doses of iodine, thinking that that's helping their thyroid. And oftentimes what you can actually do is flood the system with iodine, and it doesn't actually help the thyroid. It gets in the way of thyroid function, particularly if there's an autoimmune cause. So you do have to be cautious. You can't just go blindly and take a very high dose of iodine and expect it to work for you. But all of these things, all of these nutritional supplements are really helpful in supporting the thyroid. It's not just about supplements, though. It's also about foods, because I'm a believer when we can get a nutrient from our food, that's always better than swallowing a bunch of pills. If we don't eat certain foods, or if we're super deficient on something, sometimes it makes sense to take a supplement. But if we can do our selenium, for example, through eggs or oats or Brazil nuts, I love Brazil nuts for thyroid. And the interesting thing about Brazil nuts is if you actually take 2 of them and you put them back to back, they look like a thyroid gland. So it's kind of cool that if you just do two Brazil nuts a day, you're basically supporting your thyroid. Iodine obviously comes from kelp and seaweed, eggs and dairy products. Tyrosine is from meat, not just red meat, pork, chicken, poultry, fish. If you're vegetarian, it comes from tofu, and it also is present in legumes and nuts. Iron is in legumes, lentils, peas, things like that, meats, not just red meat, but also other meats, and leafy greens. And magnesium is in high amounts in leafy greens, seeds, particularly these little pepitos or pumpkin seeds. They're really high in magnesium. And avocado. Obviously, this is not a comprehensive list of foods that contain these things, but these are the ones I tend to go to when I'm helping a patient choose foods to correct the deficiency or to support their thyroid gland. So as I was alluding to earlier in our talk, there is an interaction between all hormones in the body and the thyroid. And so I want to just, in a very superficial way, this is a talk in and of itself, so I'm not going to give this due diligence, but there is a lot of interaction between these hormones and the thyroid gland, and I just want to illustrate how that works. So you'll remember the hypothalamus and the pituitary as our master glands. In the case of stress, I want to just talk a little bit about the physiology here. The adrenal glands are these little snow peaks that sit on top of each of our kidneys, very active glands involved in stress, involved in fight or flight, involved in anti-inflammatories, some sex hormones, estrogen, progesterone, testosterone, and then they create a whole host of hormones that are actually also involved in our fluid balance, our cardiovascular system, et cetera. They form an axis called the Hpa axis, hypothalamus, pituitary, adrenals, Hpa axis, really important in adrenal fatigue or Hpa axis dysregulation, might be something that you've heard about. That's what we're talking about when we're talking about that. So the Hpa axis exerts its effect through ACTH, which then affects a certain part of the adrenal, and you manufacture DHEA and cortisol. You obviously also manufacture epinephrine, norepinephrine, or adrenaline in fight or flight response. But for the sake of our conversation, we're talking about the stress hormones that are involved in chronic stress. So what happens with thyroid when there's stress is there is a dual action by the influence on the hypothalamus and pituitary that we just talked about over here, where the stress is responding to both of those areas through those master glands. But also there is an inhibitory effect of cortisol shutting down TSH and also shutting down T4 to T3 conversion. So as you might imagine, if cortisol levels are off, our thyroid impact is going to be huge. So we want to actually understand the impact of cortisol if somebody has reported a great deal of stress, and I really don't know anybody who hasn't reported a great deal of stress recently, but understanding the adrenals underneath the thyroid really allows us to comprehensively treat both if there are underlying problems there. Similarly, the sex hormones, estrogen, progesterone, and testosterone, influence the thyroid through something called thyroid binding globulin. So TBG is the protein in the blood that carries thyroid hormone. All of our hormones have to be carried by a protein because they're fat. They're a fatty substance. And if they were to try to travel around the bloodstream by themselves, they would float out just like oil and water. So they actually have to be attached to something to move to its target. And in the case of thyroid, we call that thyroid binding globulin. Estrogen impacts that by increasing TBG. It lowers TSH and increases T3 and T4. So understanding estrogen balance obviously is very important to thyroid function. Similarly, progesterone and testosterone decrease TBG. So when someone is having sex hormone imbalances, they could also be the underlying cause of thyroid disease. And so if we didn't understand that, we might go right over the top of these things, go right to thyroid and say, oh, it's the thyroid's fault, when it's actually maybe potentially somebody else's fault. Or everyone's fault altogether. So as I talked about earlier, I did want to very, very briefly touch on genomics. This is a really hot area of study. What we do know is that in the case of autoimmune thyroid disease, both hypo and hyper, so both Hashimoto's and Graves' disease, 68 to 75% of that is hereditary. And I see this all the time. And as I mentioned with my patient, Elizabeth, a lot of times patient will tell you, my mom has it, my sister has it. It's a lot of women particularly, but I have men who have brothers and dads who have thyroid disease. So a lot of it is hereditary. There's probably also environmental causes, people who grow up with large exposure to certain heavy metals or certain types of industries or in certain areas of the country where deficiencies are common, selenium deficiency, iodine deficiency. So there are other causes, but a large portion of thyroid disease is genetic. And we're starting to understand which genes are involved in this. So we've so far figured out that some combination of these genes, I'm not going to list them all out for you, are probably some of the levers behind Hashimoto's. I don't think we have the whole story here. I do think that there's more to it, and I don't think it's going to be a single gene that's going to be responsible, nor do I think anybody who has these genes are necessarily destined to become hypothyroid or develop Hashimoto's. A lot of it is under the influence of how well we treat ourselves, how healthy we are, et cetera. And these are the genes that we know are associated with Graves' disease. What's interesting and what I want you to walk away with is not that you should run out and get genetic testing because it's a big topic, but sometimes I will have a patient who has a really nice response to thyroid medication and his or her T3 and T4 and TSH are just looking sweet and the reverse T3 is right where we want it. And they're telling me, I don't feel right. I just don't feel like things are good. And particularly, I just don't feel like my thinking is good. I feel like my head is still not great. I feel like my body's working okay, but I don't feel like my mentation, my thinking, my mood is better. And when I hear that, I often think, these might be people who have what we call single nucleotide polymorphisms, changes in DIO1 and DIO2 that might mean that they would need a little bit more T3 than you would suspect they do. And when I check those genes, oftentimes I find problems there and I think, oh, okay, this explains why they're not responding the way they should. So that's just a little tidbit about some of the ways that we're making use of these types of tests to further understand what people's risks are and how we might treat them better if we understand more about their workup and their history. So I'm going to give a shameless plug now to Vytal Health for just a couple of minutes. So Vytal Health is an online or telemedicine company focused on functional medicine. We deliver every bit of our care online, so you never have to leave your home and office. We have physicians from across the country who have expertise in not just thyroid, but all kinds of aspects of functional medicine, gut, hormones, autoimmunity, fertility, you name it. We manage all of it. So you have the best people coming to you here in Wisconsin, if you're joining us from Wisconsin, to you to be able to help you manage your functional medicine problem. And the way it works is if you're not sure whether you have a functional medicine problem, you can take a symptom quiz right on our website. You book your appointment right online. You have your video visit. And as I mentioned, functional medicine is all about spending quality time with you. 60 minutes is our initial visit. We can send at-home test kits if that's appropriate for your care to you. And then you can maintain an ongoing relationship with your doctor through telemedicine. I think a lot of people associate telemedicine with urgent care, where it's like 10 minutes and you're getting your sinus infection diagnosed. In our case, it's an ongoing relationship via telemedicine. And because so much of it is conversation, it works really, really well. So I'm going to stop. I think we have about 15 minutes left if I'm looking at the clock right. And we can take some questions. Let me stop sharing. Sorry, I got to lean over here and stop sharing. Omar, do you want to take it back? You're muted. There you go.
Okay, Dr. Tiffany, I took it back and I have some questions here.
Great.
That I'm going to direct to you.
Mm-hmm.
I have someone asking, when do I know that I need to change my thyroid form of medications? I am taking levothyroxine. How do I know that it's not the best form for me from everything else that's like thyroid medication that you mentioned?
Great question. So if you have not had a full thyroid panel, and now you know what a full thyroid panel is, TSH, free T3, free T4, reverse T3, thyroid antibodies, it helps to understand where you are. A lot of times when I see people coming in on just T4 or Synthroid or levothyroxine, what they don't know is whether they have autoimmunity. They don't know whether their T3 is optimized. And so when we look at those labs, we can actually say, hey, it looks as though your labs just aren't optimized and you're not making enough T3 from your T4. So we might say we could increase your dose, or we might say this is a good opportunity for us to try adding T3 or switching over to a T3, T4 combination medication and seeing how you feel. So I believe it's about understanding exactly where you sit with respect to your thyroid health, and then trying different things to see what works best for you. In my experience, most of the people that come to me or the other physicians who treat thyroid at Vytal Health, they've been trying to work with their Synthroid or levothyroxine, and it just doesn't work. They don't feel right on it. And part of it is that they just never have had anything but a TSH done. And when we look at their T3 and their other labs, we're astonished to see that there's so much opportunity to make their T3 better, to deal with their autoimmunity that's underlying. And when we start moving those levers around, we start to get a lot more response, and people feel immediately better. It's quite striking. And most patients know this already. They've researched it online. They're smart. They know what they need, and they just can't get it when they go see their doctor. So it's frustrating.
Right. Okay.
So many options.
Awesome. I have quite a question here. A patient, Jill, tell us, I have RA, rheumatoid arthritis, and I have had it for over 20 years, entering menopause time of life, and now came down with Hashimoto's disease.
Yeah.
Could the link be my 6 hormones creating the issue instead of blaming the thyroid? How would this be discovered now after going on T3, T4 compounded medication from Wiltopia for the last 8 months?
Boy, that's a great one. So just so we understand, people who have autoimmune disease, and I have rheumatoid arthritis as well, we autoimmune people are at risk for other autoimmune diseases. There's something about the way that the immune system learns to misbehave that we have to be alert to the fact that there may be other autoimmune diseases that'll pop up. So it's not uncommon for people to develop other autoimmune diseases over time. So if it is a Hashimoto's underlying cause, then yes, it's amazing what menopause can do to really start rocking the boat. And now we saw how estrogen and progesterone interact with the thyroid hormone. Could there be an influence of a menopausal transition on one's thyroid? Yes. Now, can I tell you that estrogen and progesterone decreases in menopause caused the Hashimoto's? No. Do I think that they could be contributing to how you feel and your need for thyroid hormone or not for need for thyroid hormone? Absolutely. These hormones all dance together. And so it's important to understand that there is opportunity to look at all of these hormones and perhaps by, if it's the right thing, replacing hormones. Sometimes that allows people to decrease doses of thyroid. Sometimes it allows people to get off of thyroid medication. It just depends on what the underlying cause is. So if it's autoimmune, it becomes a little harder, not impossible, but there's nothing like perimenopause and menopause to really rock the boat. And I only know that because I'm an autoimmune patient. I'm a menopausal woman. I've been through these things, and I do understand that there's a lot of moving parts here, and you really need to have somebody who understands how to manage all of that. I hope that was kind of a long-winded answer, but I hope that answered the question.
Right. Thank you, Dr. Tiffany. I have another question from a patient. I have most of the symptoms of Hashimoto's, but also some of Graves' disease, like problems with eyes and weight loss. What does this mean?
Ooh.
That,
that's interesting. Well, okay, so one of the things that I theorize is that some people actually start off as Graves' disease and may go unnoticed, because actually, if it's a low level of Graves' disease, they actually feel pretty good. Their energy is great. They're very motivated. They feel pretty good, and so it may not be a time where they would actually go seek medical care. They might be thinking, I'm actually feeling on top of my game. It's only when their thyroid starts to become tired from all that autoimmune assault, when they actually start to become more hypothyroid, that gets their attention. They're sluggish, they gain weight, and they're thinking, gosh, something is wrong with me, and they'll go to see the doctor. When I said earlier in the presentation why I would check a thyroid globulin antibody on somebody who I suspect is low functioning thyroid is because these things happen. I have lots of patients who have both. They have both TPO antibody and they have thyroid globulin antibody. So they may have been on a spectrum for many years and just not known it. The other thing to note is that people swing back and forth, and I have many of these patients, and my colleagues do too, where they're primarily one form of autoimmune, but sometimes they behave the other way. And we have a very tight management of those things, because sometimes we're actually downplaying their thyroid, and sometimes we're actually supporting them with thyroid hormone. And you have to be able to know what you're doing there. It's not an easy thing to be able to balance those two things. But yes, you could have both hyper and hypothyroidism happening at the same time. And that's the reason why doing all the antibodies and doing all the thyroid tests is so important.
Right. I have another question. What's the role of probiotics to support a healthy thyroid?
Oh my gosh. Well, in functional medicine, the gut is the center of the universe. So we didn't talk a lot about gut in this presentation because that's a whole other talk. But the gut is responsible for the manufacturing and the detoxification of hormones in the body. So a healthy gut is definitely a very important step in a healthy body and a healthy hormone production. It also is an incredibly important place where we decrease inflammation in the body. It's a place where we interface with the environment. And so if there is inflammation in the gut, it is triggering inflammation in the body. And so probiotics and a healthy gut can go a long way to deflaming, decreasing that autoimmune response, decreasing those antibodies. So knowing gut health is, and supporting gut health is a really important part being healthy, but also having healthy thyroid function.
Okay, Dr. Tiffany, I have a question, personal question. How often do you see patients who have normal thyroid, or is
How
it like
often,
very high?
how often do I
Yes, it's
see
like
them?
yeah. So I mean, like, because from the population, like, are we
Mhm.
talking about very high percentage of people that have thyroid irregularities, Hashimoto's, or
Yeah.
Graves? Like,
Yeah, I think it's on the rise, which is, it's a little hard for me. I think the literature would tell you it's on the rise. Why that is, nobody really knows. I think a lot of it has to do with environment. There's a lot of information about the use of bromelain in the baking process that is similar to iodine. So it competes with iodine in the thyroid. So there is a lot of I'm seeing a lot of subclinical hypothyroidism, not autoimmune, more and more of that over time. Yeah, it is a really common problem, but it is not the only reason that people feel the way that they do. And so I also want to say, don't be myopic here. Don't just have one lens that you're looking at this through. You definitely want to have a full evaluation of your thyroid if you suspect your thyroid. But if it's not your thyroid, it's not your thyroid. We need to actually look at adrenal. We need to look at gut. We need to look at hormones. We need to unpack it. Sometimes I'm wrong. Sometimes I'll say to a patient, I think your thyroid's problematic, and we do the whole thing and it's not. So, knowing everything, or at least peeling that onion, as I said earlier, starting here, look at thyroid, and then keep going. If you're not getting your answer there, get down to the root and figure out what's really at the cause. Did that answer your question, Omar?
yeah,
Okay,
I think so. I
good.
think there is a spectrum, and then
Yeah.
many of us are moving in the spectrum.
Yes.
And that takes me to the next question. A patient is asking, if I take thyroid medication, is this a life sentence? Will I
Mm.
ever get off drugs?
I hear that so much from people. No, it is not a life sentence. I would think about it as a way to treat a problem that you're having now, get you feeling better. And then if we can get the underlying cause dealt with. So if we have deficiencies or we have autoimmunity and we address some of those things, yeah, sometimes we can get people off of thyroid medication. I can't promise people that. It sort of depends on when it's discovered. If it's been sitting there for a really long time, it might be harder. But no, I never say it's impossible. I never say this prescription is yours for the rest of your life. Good luck. That's not the way I view it, because I think that there are other opportunities. And I'm presuming all of us, because we're interested in functional medicine, are going to live a really long time. And we are getting smarter and smarter and smarter about all of these things. So who knows what we'll see in the next 5 to 10 years. We might be able to regenerate thyroid cells, for example.
Wonderful. That would be
You never
great.
know. Right.
You never know.
You never know.
Okay, I have a very good question, I think. Is gluten-free diet, gluten and dairy-free diet, is this recommended for every patient with Hashimoto's?
Not necessarily dairy-free, but gluten. There is something about the gluten molecule that tends to be triggering for people who have Hashimoto's disease. And I have seen patients go from Hashimoto's to celiac disease and then on to type 1 diabetes, which is the autoimmune form of diabetes attacking the pancreas. I've seen that triad happen more times than I'm comfortable. So we can test for gluten sensitivity. We can test for celiac disease. We can test for the genetics that are involved in gluten sensitivity. But what we don't know is who is the person whose gluten intake is going to impact their autoimmunity. So I've just made it a rule to recommend, especially now because gluten-free living is easier than it's ever been, recommend a gluten-free diet. Dairy is different. Dairy is something I would probably measure a person's sensitivity to before I'd recommend that. Not that I'm such a fan of dairy and I feel like everyone needs it, but to tell people that you have this autoimmune disease and now you have to give up all these foods that everybody else eats, sometimes is a little hard to take. So I try to do it in a very personalized way.
Very realistic.
Yeah.
Okay, I have this question. How to make an appointment with you or with one of the practitioners on Vytal Health? I think I can answer this for you. Vitalhealth.com. It's a very easy website to book the appointment through, right?
Exactly. Mm-hmm. Yeah, you can actually go right to the website. All of the practitioners that practice with us, and I handpick all of them. So they're all people that I think are exceptional quality. They're all on there. You can read their bios. You can read about what what they've experienced themselves. We actually have one of our doctors who has Hashimoto's disease. And so she's really great because she's been through it. I haven't, but she's been through Hashimoto's and had that as a really transformative experience for her to spur her on to want to become a functional medicine physician. She's an internist. So you can just go right on the website, read about the doctors, book the appointment right there. It couldn't be easier. You don't have to wait till the phones come on. You can call if you want, but it's just as easy to do it on your own time.
Great, doctor. Okay, so I have Hussein asking, you mentioned the low carb diet can affect the thyroid. So is keto diet not recommended?
You know, it depends. If somebody is in the throes of managing their thyroid and we're discovering that the thyroid is a problem, that is not necessarily a time when I'd be recommending very significant dietary changes, nor would I be recommending very strenuous exercise regimens. I would still be recommending a healthy diet, a balanced diet. I would still be addressing weight loss. I would still be looking at what people's needs are, but I would not be telling them this is a time to stress your body with a very large shift in the way that you approach your nutrition or a very large shift in the way that you approach your exercise, because we want the body to settle down, heal, and then we can go on from there. But yeah, I do think that these things are hard. And I think mostly they're hard on the adrenals more than the thyroid. It's just really hard for the body to kind of be in that mode all the time.
Great. I have a very important question. A patient
Okay.
says, I am from Belgium. Will I get treatment if I go to America, if I come to America? So the patient is in Belgium. So are you able to like help a patient who's actually in another continent, another country?
We cannot see a patient who's in another country. So in other words, if they're there, we can't have a telemedicine visit. And that's just about the US licensure laws. It's not because we don't want to help, but the US licensure laws we have to stay in the States. But if the person is visiting the United States and is physically here, especially if they're here long enough to be able to undergo testing and have a care plan, sure. If they're in the United States for a period of time, they could access our services.
Great. And I just want to mention that vytalhealth.com is written VYTA Health. And we're going to put the link also on our social media platforms to make sure that you can
Vital
reach.
with a Y.
Vytal with a Y. Okay, I have one last question about, thank you so much for this informative webinar. It's like a crash course of the thyroid gland. So thank you for that. Are there any future webinars that we can attend and listen to and learn from?
What do you think, Omar? Should we do another one?
I think it's wonderful. We can reach for next one.
Sure.
And
yes.
I think we have an array of topics we can talk about, like we have bioidentical hormones, we have different types of diets, like we can agree on something and then arrange for it.
Audience, feel free to weigh in. Tell us what you want to hear about. I just think it's really important for people to be really smart, and we all want to learn about how our bodies work. So doctors are teachers, or at least they should be. That's the root word of doctor is docere, which means teacher. So we want to teach. And so if there's particular topics that you want to hear more about, let us know. We will bring the experts. It's not always me, but we'll bring the experts to help.
That is beautiful. And this is the vision of Wiltopia and how we started. We wanted interesting information. That's information that we need. That's not redundant. That's something that sticks in, and some information that we can use to empower ourselves and grow and be able to live healthy and be happy. So by that, thank you so much, Dr. Tiffany, for this wonderful webinar. And again, you can always connect with Dr. Tiffany and the other practitioners on the Vytal Health platform by going to vytalhealth.com, Vytal with a Y, and communicate with practitioners on the platform. Again, thank you, Dr. Tiffany. And I want to tell the audience that the recording is going to be available. We're going to send it to everyone who registered, even for those who registered and couldn't attend with us. And the recording also is going to be available on Wiltopia Facebook page. And by that, we end our night tonight. And thanks everyone again.
Thank you, Omar. Thanks everyone for attending.
Thank you so much, Dr. Tiffany. Take care.
Thanks.
Have a wonderful night. Bye-bye.